Hello, my name is Dr. Deborah Cohen, and I am the MAVEN Project Coordinator today. Thank you all for joining us and our friends at Clinica Sierra Vista in Bakersfield for hosting today's session, Anti-Rheumatic Medications for the Non-Rheumatologist. It's being given by Dr. Katherine Upchurch. Dr. Upchurch retired from the UMass Medical Center, where she was the clinical chief of rheumatology for over 10 years. She is professor of medicine emerita at University of Massachusetts Medical School. Dr. Upchurch's abiding passions have been the care of patients with all rheumatic disease and also medical education. She has been a leader in the Massachusetts Medical Society and the American College of Rheumatology, and was selected in 2017 to be an American College of Rheumatology Master. In 2015, the New England chapter of the Arthritis Foundation honored her with the Marion Ropes Award for Excellence in Arthritis Care. And this year, MAVEN has honored her with their Champion Award. Dr. Upchurch is a very valuable member of our organization. So with that, Dr. Upchurch, please begin.
Okay. Hello, everyone, again. This is the last lecture in a series of lectures that I have been very happy to present to you all. And each one has built on some of the others preceding it. If you're new to the series of lectures and I refer to the others and you have questions, just bring them up at the end, or alternatively, any question that we don't get to, I will be happy to answer after the talk. Stick with me because we're going to go on quite a ride. There's a lot of information, but hopefully you'll learn some very relevant things for your practice. Let's see. Well, okay. These are the disclosures. I don't have any. We've already talked to you about the accreditation. So today we're going to talk about the different classes of anti-rheumatic drugs. And we're going to review some of the indications for the use of anti-rheumatic drugs. And of greatest interest for you all, I suspect, is common adverse effects of anti-rheumatic drugs. And then I will focus on the primary role of caregiver in monitoring and prescribing these drugs, because really and truly, rheumatologists feel that the primary care physician is a very valuable partner in terms of approaching patients of all ages, not only elderly patients, but patients all the way into their early 20s, in fact, at the beginning of adult medicine. So I will spend some time at the end of the talk reviewing that role and how you can particularly help. Okay, so what is an anti-rheumatic drug? Well, to understand that, you have to understand what a rheumatic disease step is. And according to the CDC, rheumatic disease is a disease which affects and usually causes pain in joints and also in periarticular structures, including tendons, ligaments, bones, and muscles. And anti-rheumatic drugs are drugs that produce demonstrable, some more long-lived than others, symptomatic benefit in patients with rheumatic disease. So it's a very general class of drugs. Now, there is a formal classification that has emerged as more and more drugs have become used in our class of diseases. And broadly, we have the rapidly acting anti-inflammatory drugs. And these are drugs that are absolutely helpful often in temporarily alleviating pain, but they have no potential to prevent joint damage. And the most familiar to you of these rapidly acting drugs would be the nonsteroidal anti-inflammatory drugs and also corticosteroids, although there has been some literature to suggest that there may be some disease-modifying potential of corticosteroids, although slight compared to some of the other agents. And then the next classification, next class would be disease-modifying anti-rheumatic drugs. And we use the acronym DMARDs, disease-modifying anti-rheumatic drugs. So fundamentally, if a drug has no opportunity and no chance of having any impact on the outcome of the disease, they are not DMARDs. And if it does have if a drug has a likelihood of having a impact to reduce or prevent joint damage, preserve joint integrity and function, these will be considered DMARDs. The other point about a difference between the two is the speed with which they work. So most all DMARDs are basically slow to have onset of symptomatic relief and disease lowering potential, and they're quite slow acting. We're talking weeks, sometimes months even, but certainly not hours, which is what we would expect with a rapidly acting anti-inflammatory drug. Now, let's see, this little, pardon me, there we go. So I'm going to start with a case. So a 35-year-old man presents to your office after, quote, twisting his left knee in a fall. And the past history is pertinent for the fact that he was born with one kidney, but he's had normal renal function throughout his life. On examination, his knee shows full range of motion. There's slight pain on motion, and he has a small effusion, in addition to which he has a limp. So the best approach, and you don't have to answer now, but you can jot it down and I'll ask you to tell me at the end of the talk, perhaps, or just guess what you would say. But the best approach would be acetaminophen up to 3 grams per day, ibuprofen up to 800 milligrams 4 times a day, celecoxib up to 400 milligrams twice a day, or diclofenac 75 milligrams twice a day. So now we're going to talk about non-steroidal anti-inflammatory drugs, lovingly referred to as NSAIDs. And there are basically 2 general classes of these. One is conventional, and they are non-selective as far as cyclooxygenase inhibition. So all of these NSAIDs do inhibit some or all of the cyclooxygenase enzymes. And so the conventional ones inhibit both COX-1 and COX-2. And there's many of these that are prescription drugs and also many that are over-the-counter drugs, the most familiar of which to you would be ibuprofen and also naproxen. Ibuprofen is the generic name for Motrin, and celecoxib is a generic name. I'm sorry. Well, anyway, ibuprofen, and you can get Aleve over the counter. That's naproxen, and there are others that are available for over the counter. In response to the observation that the non-steroidal anti-inflammatory drugs had a high incidence of gastrointestinal intolerance, there was a great deal of effort made to develop what was called a selective inhibitor. And the selective inhibitor was built upon the fact that COX-1 confers gastroprotection against the formation of ulcers or even gastritis, whereas COX-2 does not. So a drug that inhibits COX-2 does not lead to any exacerbation of gastric disease, whereas the many previous over-the-counter or prescription medications that inhibited COX-1 had a much higher incidence than the COX-2s of causing ulcers and gastritis. Now, there was a great splash when these came out, and probably you all are young enough perhaps to not even have been around when this happened, but Vioxx, VIOXX, was the buzzword in this class, and everybody prescribed Vioxx for just about everything. And it turns out that Vioxx was quite toxic, caused a lot of renal insufficiency and gastric disease, and was eventually, after many moons, completely taken off the market, as were most all of the COX-2 of the selective COX inhibitors. Now, the only one that is selective that's available is celecoxib. And this is actually relevant for you to know, and we'll come back to this in a little bit. Not only do the selective COX-2 inhibitors have a lower incidence of gastric issues. They also don't inhibit platelet function. So they're reasonable drugs to use if an anti-inflammatory drug is used at all in patients who are anticoagulated, still with a great deal of caution, but nonetheless far more safely than drugs could be used that do inhibit platelet function, such as the standard non-selective cyclooxygenase inhibitors. This is just a generic list. You can come back and look at it. And I've circled celecoxib as the only one that is a COX-2 inhibitor. There's some that are almost COX selective. Meloxicam is one that's almost selective. But the rest of them basically can be all thrown in a bag together because they all have the same amount or at least significant adverse effects related to inhibiting both COX-1 and COX-2. So when do you use NSAIDs? And it's always with caution, particularly in older individuals. I've seen a lot of trouble that's been generated by a provider often giving, without even thinking about it, NSAIDs to older individuals in particular who have multiple medical problems, are often on multiple medications, and just frankly get into trouble. And sometimes even younger patients can as well. And that's related not only to the mechanism of action, which I've talked about, but also to other adverse issues. There's one thing that you should know about as a primary physician. So you take care of a lot of older people, and elderly females are at greatest risk for gastritis and gastrointestinal bleeding from anti-inflammatory drugs, particularly the non-selective older variety. I just think it's a better idea to stay away from non-steroidal anti-inflammatory drugs in older individuals unless it's just absolutely necessary. The second issue that is often a problem, particularly in older individuals, but also in our Proban patient, case number 1, is that these drugs do have an impact on the kidney. And there's a serendipitous almost allergic response that some patients experience, which is acute interstitial nephritis. It's an idiosyncratic reaction, but it is something to think about if a patient who was recently started on an NSAID has the development from 0 to 60 miles per hour, essentially, of worsening renal function, is the presence of this acute interstitial nephritis. And then the other thing is just patients who are older, as I'm sure all of you know, have lost some of their ability to filter, and they may appear to have normal creatinines, but still have lower than normal creatinine clearance. And these drugs basically diminish renal plasma flow. So they can go into acute kidney injury starting with the normal creatinine, because most of the time we don't just do creatinine clearances on everyone. And we don't even think about the fact that an elderly woman with a low muscle mass and a creatinine of 0.8 might end up having a significantly reduced creatinine clearance. So we put her on a standard dose of, say, ibuprofen. The next thing we know, she presents with renal failure. Now, I already mentioned that these drugs cause increased bleeding due to platelet cyclooxygenase inhibition. And again, celecoxib is the only one that you can give and not have to worry about this. So that's an important clinical point if you do end up needing to offer someone these drugs. And there are a very few select circumstances when you might. An absolute contraindication to using these drugs, and this is, I would, if you're taking notes, put 3 big stars next to these, is that patients who have a history of aspirin allergy should not be put on anti-inflammatory drugs because there is a risk of anaphylaxis. And the other thing is these drugs can exacerbate asthma. So if you think they need these agents, and gosh knows I would have to be, nailed to the wall before I would give them in most of these patients with pulmonary issues, really they would best be introduced to them in the emergency room. So points to take away from this slide, I think, are many, but the generic overriding point is that these drugs are not to be considered lightly, and that even includes over-the-counter medications, although the doses that are often taken from the over-the-counter group are quite low compared to the full dose. For example, ibuprofen in its full strength is 800 milligram tablets, whereas the over-the-counter ibuprofen tablets are 200 milligrams. Okay, so I hope that you all have learned that the answer have figured out that the answer to our first case is that you want to give him some acetaminophen and see if that, and tincture of thyme, and see if that might help him get better. The reason simply is that we know he has diminished renal function. He might be able to clear creatinine and to clear the other toxins that are presented to his one kidney, but we don't want to do anything to jeopardize that function. We don't want to expose it to acute interstitial nephritis. We don't want to expose it to anything that might reduce his renal functions. And any one of these drugs, ibuprofen, celecoxib, or diclofenac, certainly could do so. So the practical implications, just to review again, avoid NSAIDs in patients who are volume depleted. I didn't mention that earlier, who have chronic renal insufficiency, or the elderly who are at risk for renal disease. Avoid in patients with a history of PUD. Always offer NSAIDs with food, and in the elderly individuals and women in particular with PPIs. Use with caution in the history of thrombocytopenia, and if you do need to, for some reason, give these drugs, offer celecoxib with very careful monitoring in patients on warfarin. There is, or the other anti-thrombotic drugs that we're now using. The celecoxib can cause a serendipitous, unexpected, very high blood level in a very small group of patients in which there's hardly anything that you can do but stop the drug altogether to deal with it. So these are just basically difficult drugs if you don't think about all the options and stay away from them in a selected group of patients. And again, it's an absolute contraindication in a patient with a history of aspirin allergy. Hopefully, I've driven those points home. Okay, so I'm not going to spend very much time talking to you about corticosteroids because it's a subject that'll take up 2 or 3 or 4 lectures, and I'm sure Dr. Cohen can do a lot of talking about prednisone as well as me. But it is true that it's one of the most widely prescribed drugs on the market. It has many, many uses. There is a distinction between low-dose, short-term, and high-dose, long-term prednisone with regard to adverse effects. I mean, if you have an allergic reaction from bee stings, you're going to get a high dose in the emergency room intravenously. Then they're going to taper you off over the space of 4 or 5 days. And, I've known patients who basically categorically refuse to have any dose of corticosteroids. And I can comfortably say that it's highly unlikely that they're going to have a major problem. The one exception is patients who receive very high doses intravenously who have diabetes will have a hyperglycemic effect almost certainly, and they have to be watched carefully in that regard. But there are other metabolic consequences. There's CNS issues, there's osteoporosis, there's resistance to infection, all sorts of things with metabolic, all sorts of things with high-dose prednisone. And that's all I'm going to say about corticosteroids. Perhaps next year I'll generate a lecture just on using corticosteroids in rheumatic disease because it is quite a helpful agent. And in some patients, it's very challenging to treat them without using some dose of corticosteroids. But at the same time, we still always consistently try to offer other agents to reduce corticosteroids to a minimum. Okay, so now I'm going to turn to the meat of this talk. And that is the long-acting agents that have the potential to modify the course of the disease, of the rheumatic disease in question, disease-modifying anti-rheumatic drugs, 2025. And this is basically the different groups that we break this group down to: traditional, which are synthetic DMARDs, biologic DMARDs, and then there's some targeted synthetic DMARDs that are not broad brushstroke, but they're targeted against specific metabolic pathways. And then the final thing that I'm just going to talk about for 5 seconds is biosimilars, which are drugs that are made to have identical actions as some of the biologic DMARDs, but are generated in a less expensive way and were hoped to have to convey less cost to patients who needed biologic drugs, but it really hasn't turned out to be that way for a lot of complicated reasons that I'm not going to discuss at this point today. But these are the different groups that the DMARDs are divided into. Okay, so here's another case for you. So a 33-year-old woman presents to her nurse practitioner complaining of nausea. Her history is pertinent for long-standing psoriatic arthritis, well controlled with adalimumab and methotrexate. She has no other medical problems, and her pregnancy test was positive, despite the fact that she'd been using an IUD and an LMP. And she asked what should be done. So your advice: 1, discontinue methotrexate, continue adalimumab. 2, discontinue adalimumab, but continue methotrexate. C, continue both. D, discontinue both. E, consult her rheumatologist. So we'll come back to that and discuss it briefly too after I go through the next few slides, which hopefully will give you some answers. So when I started practice in rheumatology, which was in about 1979 or 80, we used oral and intramuscular gold. And methotrexate was not an approved drug for the treatment of rheumatoid arthritis, and it had just been approved to treat psoriatic arthritis and psoriasis, which is hard to imagine because I'm getting up in years, but I'm still alive, and it wasn't that long ago. And so methotrexate, when I started practicing, became favorably accepted, even though not yet FDA approved, because we looked at the patients with skin psoriasis, and we saw that their joint disease, which occurs in about 15 to 20% of patients who have skin psoriasis, improved when they were on methotrexate. And so from that observation came clinical studies which confirmed that methotrexate would be useful in rheumatoid arthritis and then subsequently some other related conditions. Now, methotrexate is often now used in combination with other traditional and also biologic DMARDs, and sometimes in combination with non-steroidal anti-inflammatory drugs or even corticosteroids. It's excreted 90% unchanged. It's highly protein bound. It's a dihydrofolate reductase inhibitor. And in rheumatoid arthritis, it's given as a low dose once weekly, either orally or subcutaneously. And it's given with folic acid to try to overcome this inhibition effect and side effects that might happen as a result of this dihydrofolate reductase inhibition. You might say, well, doesn't that inhibit the effects, the positive effects of methotrexate? Well, it turns out it doesn't. So we typically do prescribe folic acid to be given with methotrexate. Now, there's one thing that you can be very helpful about, and when you see patients who are on methotrexate, probably you would not have been the one to initiate it. I would guess that a rheumatologist might have done so. But a lot of patients get confused about the concept of taking methotrexate 1 day a week, or the prescription for some reason is not transcribed properly, and it might say something like TI weekly. And so it looks like 3 times a week. So the patient might take one on Monday, one on Wednesday, and one on Friday or Saturday. And it turns out that that approach is more toxic than taking the methotrexate all at once a week. So it never hurts, and it often can be a big help. If you see that methotrexate is on the patient's med list, just ask them how they're taking it and verify that, yes, they're only taking it one day each week, because it happens. And I've seen it happen many times. And I've seen some patients have some really bad side effects, particularly at the higher dose ranges as they get towards the maximum. So that's a way that you can be a big help. Now, it's generally well tolerated, but there are adverse effects. So nausea, sores in the mouth, diarrhea, and the dose that the patient's on can be lowered if possible, and often that does help. And that would be even with orally. And if patients have nausea, if they are switched to subcutaneous injections, that is a way to get around some of the symptoms as well. It's not infrequent for patients to have abnormal liver function studies, and the literature is just, there's so many articles about methotrexate and related hepatotoxicity that I'm sure I haven't read them all, but it's way more than I think is indicated, and yet they're still turning up. The fact of the matter is, anything up to twice normal is not too bothersome, and it's often associated with the fact that the patient has their lab work drawn the day after they take their methotrexate, whereas if they had had their lab work drawn the day before, the liver functions often might be normal. And very minimal abnormal liver functions don't reflect chronic liver disease for the most part. And in fact, it's very rare that patients do develop frank cirrhosis from methotrexate, even though it occasionally has been described. And it's very rare that they need to have a liver biopsy, although in the old days that was done much more frequently. I think there are other causes of abnormal liver functions that often happen in patients who are on methotrexate, such as other drugs that they use, and that also have hepatotoxicity. So it is something to work out, and it might require a liver consult to GI consult to look into it further, but it's usually not a major problem. Myelosuppression, on the other hand, is potentially a problem, and so we follow the patient's CBC, and parenthetically, we follow liver functions at least every 8 to 12 weeks and make dose adjustments as required. It's rare to see frank myelosuppression, though, and that should bring to mind other diagnoses. The other adverse effects are accentuated by using other DHTF inhibitors, such as trimethicin sulfasalazine. So if you have salicylic acid, basically Bactrim. So if you have a patient who comes in with a UTI and they're just sort of knee-jerk put on Bactrim without noting that they're on methotrexate for rheumatoid arthritis, that could be a big problem. So it's less likely to happen in this day and age because we have computers and the med lists are accurately transcribed, and we can see what drugs they're on, patients are on each time we see them. On the other hand, it's something that we should definitely think about. Use something else. We've got plenty of other things to take care of that. And if there's any question, just get on the computer and find out if any of the drugs the patient is on that you're thinking, and in particular, if you're thinking of putting a patient on a new drug, see if it has an adverse interaction with methotrexate. One thing that is absolutely crystal clear is that patients who are on methotrexate do have a very high incidence of congenital birth defects and also, therefore, spontaneous abortions. So we don't recommend that patients try to get pregnant while they're on methotrexate. We do recommend birth control in patients on methotrexate, particularly the most effective kind available. And in many cases, patients have to have early abortions because of severe congenital birth defects if they conceive when they're on methotrexate. So it's a big issue. Now, we do use folinic acid to rescue patients who have severe leukopenia, neutropenia, and hematologic abnormalities. And this is an example of a patient who had marked hematologic disease. And this is basically when she got the folinic acid here. And you can see that abruptly the problems went away. So you can rescue a patient if there are any issues in this regard. Now, the other traditional DMARDs include hydroxychloroquine, sulfasalazine, and leflunomide. Hydroxychloroquine is generally considered to be very safe, quite frankly. It can cause myopathy, including cardiomyopathy. It can cause retinal toxicity. But in general, it's not a drug that we consider to be contraindicated in very many patients. It's not a good treatment for COVID, however. Sulfasalazine, which is SSC, can cause nausea, leukopenia, and in men can cause hypospermia. And another synthetic disease-modifying drug is called leflunomide or Arava. And in some patients, we use this if they're just intolerant of methotrexate, and it's almost as a methotrexate proxy. It's used in patients who have intolerance, as I said, to methotrexate, or don't get the response that you want. It's not used as frequently now as it was when it was first available. And it does cause sometimes profound abnormal liver function tests, rash, diarrhea. And the problem with this drug is it's deposited in the soft tissues very early, and you can't just discontinue it. It takes months for the leflunomide levels to be reduced to normal in a patient having a severe side effect, such as a generalized rash. And we actually have a protocol to use drugs like cholestyramine to wash out the leflunomide from the soft tissues in that setting. So there have been some studies that have compared using combinations of these drugs, sometimes all three, and as opposed to using the biologic agents. And early on, some people felt that these drugs in combination could cause remission. I've never been at the same rate as the biologics, but I've never been a big fan of the literature or even that approach. I figure if a patient has failed methotrexate, I'm ready to consider much more aggressive treatment. And I think you all remember that I emphasized aggressive treatment in my talk about rheumatoid arthritis and also in my talk about psoriatic arthritis, because of the fact that we know that these diseases can cause irreparable harm to joint structure very early in the disease. And we don't think that there's any time to waste. And all of these drugs are very long acting and take weeks to months before they might be expected to induce a remission. So practical implications, just to move beyond these remarks and getting ready to move to the biggest section of the talk, is how to write or call in a methotrexate prescription. If the patient says, I need another prescription, could you just refill it for me? Well, you call in the pharmacy or you write it or electronically. You have to say, take all 3 or 4 or 5 tablets, whatever you're offering, one day each week. Or you might say the same day each week. Don't say TI weekly. Don't resist that. You need to check drug interactions and contraindications, and we can do that electronically. Contraceptive counseling. As far as alcohol is concerned, probably infrequent minimal alcohol toxicity at your daughter's wedding is okay. Best to take alcohol as little as possible because it'll confuse the finding of abnormal liver functions. And if you're going to check liver functions, when you do, check them the day before or the day after, right surrounding when the methotrexate dose is expected to be the lowest and the least toxic. And then, as I said, we're still checking CBC and LFTs Q3 months, although some people sort of stray a little bit away from that if patients have been on methotrexate for years and haven't had any problems. Okay, case 2. Case 3, I guess. 29-year-old woman comes to your office complaining of dysuria. Oh, this is the result. This is the answer for several days. So basically, she has a history of RA. Her medications include diclofenac, low-dose prednisone, weekly low-dose methotrexate, and oral contraceptives. How would you manage this patient? Bactrim, stop. No. Methotrexate, would you stop it? Would you give her Keflex? Would you stop prednisone? Would you request an urgent room appointment? What I would do would be that I would give her something else like Keflex and just get rid of the urinary tract infection. And I would continue prednisone. And I don't think she needs an urgent room appointment. You can do this. So the most important thing is just to remember to check all possible agents for interactions with the complex rheumatologic drugs that we prescribe. So the answer is Keflex. Now, why did we even bother to continue to look for other treatment strategies for RA and related conditions? Well, after 5 years of treatment, only about 60% of patients remained on methotrexate because of either adverse effects or it didn't work. Joint erosions were found 30% of patients after 1 year of therapy with traditional DMARDs, and in 70% of patients in some studies after 2 years of therapy. Complete remission was rarely observed, and you can see the numbers. And over 50% of patients with RA can become disabled as early as 5 years, including after 5 years of therapy with traditional DMARDs. So the traditional DMARDs that we've just gone over are useful in patients who don't have severe disease, but they just basically don't get the job done. And so about the end of the 1980s, early 1990s, the discovery, it was earlier than that, when the interleukin family was discovered. And then the whole development of the concept of cytokines became the focus of many, many research labs. And finally, about the end of the 1980s, infliximab was offered to patients with ulcerative colitis and Crohn's disease first, and then was because the mechanism of action in rheumatoid arthritis included some cytokines that were felt to be possible targeted sites for the anti-TNFs. The drugs were offered to patients early on. And lo and behold, we did see a dramatic response. And this was the class of medications that we rheumatologists basically have been waiting for. And I have just been an incredible proponent and an advocate of cautious, careful, educated use of biologic DMARDs ever since they were available to me to be used. So this is case 3. I had the 2 cases backed up, but basically, I've already presented this to you. She's been on methotrexate, and she had a positive pregnancy test, and she's been on adalimumab. So I hope that you have made your mind up already, because I put it a little bit out of order. But the question is, she's pregnant. Does she have to stop adalimumab and or methotrexate? Okay, so I'm going to go very quickly through. I'm not supposed to put any pathophysiology in these talks, but it's very difficult not to do that, particularly with the powerful approach of applying knowledge of how cytokines work to generate the use of all of the cytokine drugs that we now use. So this is a patient who had who's had longstanding joint disease. You can see that he or she has had, probably she demographically, has had marked periarticular osteopenia, marked erosions, loss of integrity of the joint. And this patient has nasty disease. And probably what's going on here is that there's an interaction between all of these different components. And you can see that a lot of them are interleukins, rheumatoid factor, plasma cell. I'm not going to go through the whole thing, but the question is, what can we do to modify what is leading to the osteoclast here, which is the multinucleated cell that destroys bone? What is leading to erosion of bone and cartilage that leads to the main pathology of rheumatoid arthritis? Well, we looked into that and we've studied it, and we basically have been using extensively many biologic DMARDs since the late 80s, early 90s, and they're only more and more and more. So these slides are up to date, probably within the last couple of years, but there have been others that have not been written on these types in these lists, which are extensive, that have come about even in the last 6 months to a year. Every time I open a journal or open even a TV ad, you'll hear the name of a drug that you've never heard of, and it turns out it's to treat rheumatoid arthritis or psoriatic arthritis. So the characteristics of these biologic DMARDs is they're produced by recombinant DNA technology. They are huge proteins. They have to be injected or infused. They generally target cytokines or their receptors, or they're directed against cell surface molecules that have an impact in that way. So in rheumatic disease, we use basically TNF alpha inhibitors, including infliximab, etanercept, adalimumab, golimumab, certolizumab, and others. The ones that are the earliest that you might be aware of are infliximab and etanercept. And this drug is the most widely selling drug in the world now to treat rheumatic disease, rheumatoid arthritis. Now, there's also another recognized antagonist, which is called anakinra. It's an anti-IL-1 receptor. There's an anti-IL-6 receptor antagonist that does work against in patients with rheumatoid arthritis who have failed these drugs. And sarilumab is also a very recent comer to these lists. We've looked at other ways to address rheumatoid arthritis, which has been generated by our understanding of the pathology of the disease. And so we've looked at B-cell depleting strategies by using drugs like rituximab, same drug that's used in lymphoma. A new drug, belimumab, has been used in lupus. A drug that's a T-cell co-stimulatory blocker, it's called abatacept, has also been widely used in concert often with methotrexate, as all these other drugs are. So the practice of rheumatology really has evolved from diagnosing rheumatic disease to developing a real good understanding of how and when to use these drugs, and what other drugs can be used with them, and how to follow patients, and when patients should be moved from one drug to another, or for one combination of drugs to another. So rheumatologists are really your friends in helping talk to you about these drugs, or if you we'll be going very shortly on over the side effects, and if you have a patient in whom you think there's been an adverse response to a drug, I think the thing to do is pick up the phone and call the rheumatologist. I don't think it's to have your nurse do it. I think it's you do it, because you are the voice that is going to command the most attention, and that's sometimes really required in some of these drugs that do have significant side effects. Okay, so this is just a schematic approach. Some of these drugs, like etanercept, are only human-derived. Others, like infliximab, have a little piece of a mouse. That's what the red is. So they're different structures, and there are subtle differences, but basically they all, most of them are anti-TNF biologics. Now, I'm going to skip through this, but if you're interested, you can read this, and it does go over some of the mechanisms of action. And this classifies the disease-modifying drugs, and I've already mentioned this previously. So we now continue to look at anti-interleukin modification, and this is the most recent area that's been developed, is the IL-23 and 12-23 and 17 inhibitors for psoriasis and psoriatic arthritis. I think the anti-TNF story and the treatment for rheumatoid arthritis has kind of been exhausted, quite frankly. I'm sure that there's still groups working on certain agents, and I'm sure that they could still be improved. But when you turn on the nightly news or whatever it is you watch, if you happen to watch any TV right now, you're going to hear about all of these: Skyrizi, Tremfya, Ilumya, Stelara, Taltz, Cosentyx. All of those have been widely advertised. And it's funny, the incidence of psoriatic arthritis is quite low, and the total number of patients as far as caseload compared to even rheumatoid arthritis is much lower as well. And you would think that everybody who lives in your neighborhood has psoriasis and psoriatic arthritis when you hear how often these types of drugs are advertised. So it's amazing how much drug development has been done. And the other thing to tell you is that these drugs cost sometimes $2 billion and up to try to develop. And I think probably what's happened with some of these IL-23 inhibitors is that companies have gotten a lot of investment in bringing them to market. And once they've spent that money, they're gonna hope that they can recoup some of it. And how long all of these drugs stay on the market is not clear, but they all have been FDA approved, and they seem to work. They all have slightly different side effect profiles, but they're excellent agents. These are just some interesting slides where you can take a quick visual glance. And so here's a patient. This is response rates. And you can see with the addition of adalimumab in all doses, there's a huge response rate compared to no adalimumab. This is radiographic progression at 12 months of anti-TNF plus methotrexate. And you can see with just even etanercept monotherapy, there's very marked improvement compared to what's expected, which is a predicted progression of disease. And the same is true with infliximab and adalimumab. This is a reduction in concurrent methotrexate dosing. So it does help reduce not only methotrexate, but also prednisone. So 55% in this cohort were able to decrease or discontinue methotrexate, and 24 were able to discontinue it, continuing on etanercept. So the same is true in steroid reduction. Only 6% of patients had to actually increase their steroid, whereas 82% were able to decrease or discontinue in this group. So it's really amazingly impressive and satisfying to see that kind of response. I did mention that when you're desperate and there's some issues with regard to safety, particularly if a patient has lymphoma and there's been some concern about using, or other cancers, and there've been some concern about using biologics with cancer drugs, with the diagnosis of cancer. It's less so now, and we'll talk about that in just a moment. But rituximab, which is a chimeric anti-CD20 selective monoclonal antibody, has been found to be helpful also in some patients with rheumatoid arthritis. This is just a drug about the safety and efficacy of that. And these back in several years ago were immune-targeted therapies in RA, and the number's even more now. Now let's talk about adverse effects. The most concerning adverse effect, and this also is where you on the front line are really incredibly important when you're co-managing patients who have RA and other diseases and are on biologics. Reactivation of tuberculosis, I'm sure all of you have heard about. And every patient who starts on one of these drugs should be tested in one way or the other for the presence of a history of exposure to TB. And there's a lot of controversy about how you test them, but they all should be tested. And if there's a definite known exposure to tuberculosis, a lot of patients are treated for that before they are started on these drugs. That's a whole little discipline in and of itself, and would basically, if a patient develops a positive PPD before they're put on biologics, I would refer them to infectious disease for their assistance. But patients not only have reactivation of TB, but they have exacerbation of recurrent, chronic, or active bacterial infections. Examples that you wouldn't think about would be skin infections, prosthetic joint infections, opportunistic infections, reactivation of Hep B. So these drugs can be bad actors. Not nearly all of them are, but the most successfully managed patient is the one that has the maximum number of eyes on them, being careful to assess symptoms early. And I always took the point of view that you should assume that a symptom that is developed and becomes chronic is infection if a patient is on the anti-TNF category. You have to assume infection and then disprove it rather than have it be the last diagnosis you think about. There's still a little bit of literature about malignancy. Probably lymphoproliferative diseases may be related. My husband happens to be a lymphoma doctor, and he's convinced that they're all terribly associated or directly associated, because he sees all the ones who have lymphoma who were on these drugs. But with many, many studies, if there is an increased incidence, it's very small. Maybe melanoma skin cancers, particularly it's been speculated that metastasis from a known melanoma. Non-melanoma skin cancers, yes, not solid tumors like lung cancer, colon cancer, etc. So a family history of lung cancer or colon cancer, or even having colon cancer or lung cancer, doesn't necessarily preclude using these biologics. They do exacerbate in certain cases, stage 3 or 4 congestive heart failure, and have to be used in great caution. It's possible that they cause exacerbation of MS. I doubt if they actually cause MS. This is a gray area, but most of us who've used a lot of anti-TNFs have seen patients who've developed MS on anti-TNFs, and we stop the drug. They can cause drug-induced lupus, which is particularly infliximab when it's being infused. Other infusion drugs, such as infliximab and rituximab, can cause severe infusion reactions, and patients who are using self-injected agents can cause injection site reactions. The self-injection causes injection site reactions. Interestingly, they're not likely to interfere with fetal development or pregnancy, and it's not necessary to stop the drugs if patients are trying to get pregnant, or to follow them as a high-risk patient if they are pregnant. And then I just pulled out the infusion reaction because it's so common in patients on infliximab and rituximab. So I did make a note down here. We do use rituximab to treat lymphoproliferative disease in patients who have RA. And when they do, interestingly, the infectious incidence is increased, but it's a little bit less than expected. And I noted that infusion reactions occurred with that drug as well. So it's never an easy thing to deal with a patient who has coexistent additional diseases. But again, just to emphasize your role is just be an extra set of eyes and be an extra set of ears. And any symptom that the patient develops that is sustained a little bit out of the ordinary, be sure and contact the patient's rheumatologist and work together to sort out where it comes from and what the issue is. I can give you way more examples than I have time to of situations when that type of partnership worked and other situations where it didn't work. And, I think the most important thing is to keep the communication channels open when you share patients who have these kinds of drugs on board. Relative contraindications, I'm sorry if this is so blurry. Anyway, history of lupus, multiple sclerosis, chronic recurrent active infection. Immunosuppression is a tough one, but it is a relative contraindication. History of TB or positive PPD untreated, that is also relative. Remember, it doesn't cause a TB, it just makes it more likely that the patient has a TB. Congestive heart failure, also hepatitis B and C, and we generally do now check serologies before patients start on these drugs. And most importantly, pregnancy is not a contraindication, and that has been often erroneously said in the past. Okay, so this is case 3, 30-year-old woman, we've talked about it, presents, her history is pertinent for psoriatic arthritis. She's on adalimumab and methotrexate. Your advice is stop the methotrexate. Her last menstrual period was 6 weeks ago. It's very early, and sometimes if you're on methotrexate when you conceive like that, you can continue to follow the fetus and don't develop any. But if you continue to offer methotrexate in someone who's already pregnant, that can be a disaster. You can continue adalimumab. You don't have to discontinue adalimumab. You should not continue methotrexate. You should certainly not continue both. You certainly should not DC both. But this is the time when that rheumatology communication channel with the rheumatologist and between the rheumatologist and the specialist has to be open. And I have so many, I've heard more times than I can count, either patients or other doctors saying, I could just never, ever get that doctor to call me back. Or I thought about calling the rheumatologist, but I don't think he wants to talk to me. Or I asked my nurse to call the rheumatologist and he never got back to her. Or my patient told me that she has a rheumatology appointment, but it's in 6 months. So those things are unacceptable. And this is when advocacy from the treating physician particularly is really important. In this case, if the rheumatologist doesn't know there's an issue, then he or she can't help you. So just continue to batter these people who are very difficult and very busy and very challenging to get in touch with, but continue to drive through and get in touch with them if you need to. Very quickly, not only the adaptive, but the innate immune process is part of the treatment of rheumatoid arthritis. It is part of the cause of rheumatoid arthritis. And we do use a targeted synthetic DMARDs, which are small drugs. You probably heard of JAK kinase inhibition, and this is a drug that it inhibits the innate immune system. And these include tofacitinib, baricitinib, and upadacitinib. These are pills. So some patients really don't want and tire of taking the injections or infusions. And these drugs actually are often additive to, they've not been used frequently with the anti-TNFs, but they have been used with methotrexate. And some patients, I've had patients who just didn't do well on the anti-TNFs. I put them on one of these drugs and they did great. Many abnormal side effects, particularly abnormal LFTs and dose-related DVT. This sort of came out of the woodwork a few years ago and we didn't expect it. And now it appears that it has some increased relationship with the development of cardiovascular disease. So all of these drugs have to be cautiously considered. I want you to read this slide because you'll get it. But there really are quite a bit of this has to do with COVID, and this was the rheumatology consensus. But COVID is a unique problem. I'm not going to dwell on it, but if you want to read it and see how we responded to it and what these drugs led us to do, you feel free. Here it is. Okay, one thing I want to tell you, and then I'm going to let you go. Hot off the press. This was published 2 weeks ago. There's a 3-year result of 2 groups of patients. One group had been on a stable dose of anti-TNF. TNF-I is TNF inhibition. And so the other group was withdrawn in a steady fashion until they were on no anti-TNF. So you have a treated group that stayed on stable dose, no anti-TNFs. And the question is, after being tapered, what happened? Well, it turns out the hope was that there would be a high incidence of being able to keep patients for the long run off of anti-TNFs, but that didn't happen. Only about 25% of the study group in which the anti-TNF was withdrawn was able to stay off of anti-TNFs. So they're still doing something and the disease is still active, and we cannot cure rheumatoid arthritis or related conditions. Okay, so that was a very, very rapid tiptoe through the treatment strategies of very complex diseases. And I'm sure that all of you have would be well served by going through these slides again. And if you have any questions, I can take them now, or if we don't have time to go over very many questions now, please feel free to send them to us and I can answer them after the talk is over. The final thing is, I read and I respond to your comments very, very thoughtfully, and I always want these talks to be better. So if you have any comments that you think would make it better, please let me know. This type of talk actually could be divided into 2 talks, but I'm trying very hard to get as much information to you as I can in a very short number of sessions, because I know how busy your schedules are and I want you to at least have some exposure. Well, thank you very much, and I'll take some questions if anybody has any or has time to ask them.
Oh, thank you, Dr. Upchurch. Very much worth waiting a few extra minutes after the top of the hour. I don't see any questions right now. And so I think there are no open questions either in chat or Q&A. So I think we can probably stop the session. But
Okay.
that was really excellent and just chock full of information. Thank you so much.
This is the call that I sent away an hour ago, so I better take it. Okay.
All right.
Okay, thanks.